Hi, my name is Nick Hodges-Pierce and I'm presenting on baby doll therapy. So sometimes ABA is hard to explain. For that kid who just won't talk no matter how many tickles or how many edibles we give him, the adult who's never going to learn math because math requires a lot of skills and a lot of covert behaviors that some people just don't have. Being able to get a picture of numbers and subtracting them is going to be difficult. That's going to make division difficult. That'll make story problems and algebra difficult. Some people just aren't going to be able to do it no matter how many skills we reinforce. I'm never going to be a good drawer no matter the task analysis that you do or the reinforcement of those small skills. I'm just not going to be a good drawer. I'm not artistic. That wasn't reinforced when I was a young kid. It's not going to happen. So what do we do when ABA isn't enough? We can look at Skinner and Baum and try to break down some of these really complex issues, but it's really hard to explain everything just using words like reinforcement and punishment. Ellen Langer is a psychologist. She did a study that she called Counterclockwise. So she took two groups of elderly men and she did a 1959 time warp. So the control group lived in this time warp. There were pictures of them in 1959. There was 1959 music. There was articles and newspapers from that time. So this environment was set up to look like 1959. And this control group lived there and reminisced. The experimental group lived as if it were 1959. So they talked about events as if they were happening that day or as if 1960 were the next year, and they lived as that. So they weren't offered any help that they were used to. So when you see an elderly gentleman with a cane, you would hold the door for them or take their bags upstairs. None of that was offered in this time warp period because they didn't need that essentially. So both groups improved, but I'm sure as you can tell, it was said that the group that lived as if it were 1959 improved a lot more. So there are some criticisms with this study and even the author. So she never published this study, so she'll talk about it and reference it, and it's even been in several magazines, but it's never actually been published. So Langer also references unpublished studies a lot when she's speaking or when she's giving interviews, which can be hard for people to follow along if none of the things she talks about are published. So casually hatched ideas was a quote that someone used, and she puts these the same as published studies. So it's kind of hard to follow her quite a bit. So she's well published, she's from Harvard, that's her brand, but she doesn't really take any of those responsibilities being a scientist. So there was no replication of Counterclockwise as of yet. So Friedman in 2015 kind of summed up all of Langer's talks and said that mindfulness, which she defined as conscious awareness and focus on the present moment, is important. Placebo effect cannot be discounted, and evidence supports the benefits of making sure that people maintain agency and independency as they get older. So I am interested in using ABA with geriatrics. I am personally interested in Alzheimer's disease and dementia. In May, my grandma passed away of Alzheimer's. So this topic really interests me. It gets me going. I would love to use it more. But as most of you know, the focus is mostly with children, so there's kind of a struggle to get that those two worlds to mesh. So one of my questions is, does it even make sense to use ABA with a deteriorating mind? And I say mind tongue-in-cheek, knowing that we don't use that phrase. The mind is not a real thing. We would use brains and neurons and different words to explain that, but that same theory is in place. So if the brain is deteriorating, if it's getting older, if it's getting sick, essentially, does it even make sense to use ABA? So, in my investigations of Alzheimer's and geriatrics over the last few years, I came across doll therapy. So, baby doll therapy is said to increase speech, it provides structure, it's also supposed to provide a calming presence. So, patients with Alzheimer's are said to have a nurturing instinct about them. While some of these ideas and Langer's ideas that I mentioned are overly mentalistic, some of them can actually be explained if we think about radical behaviorism. So the old men that I mentioned that were used to walking with assistance are no longer walking with assistance in this time warp. Walking with assistance is negative reinforcement, right? So if my hip hurts and someone helps me, that pain in my hip goes away, so I'm going to keep asking for help. If there's no one to provide me that help, there's no negative reinforcement going on, so I'm going to find another way to carry my own bags or walk without assistance. So Skinner talks a lot about conditioned seeing, which is a private event. So seeing one thing makes a picture of another thing. So you can quote unquote see it if you look at one thing. So if we are looking at pictures, actual pictures of old people, and we see nurses and we see nursing homes and beds, our conditioned seeing is going to see pictures of older people, sickness, dying. However, if we're in 1959 and we're seeing pictures of our younger selves, and we're seeing pictures of radios and seeing pictures of sofas from back then our conditioned seeing may be seeing something different. So we're not seeing death and destruction, we're seeing whatever it looks like in 1959. So if being young and healthy is reinforcing and generating young and healthy images is also going to be reinforcing. So that leads me to my research idea, baby doll therapy. So that leads us into the actual study. So these are the measures. The dependent variable is going to be verbalizations. I thought about those other things that were claimed by doll therapy. The only one I wanted to look at was verbalizations. I define that as omitting real whole words or making common playful sounds like boo or yay. Nonsense words or just sounds were not going to be counted as verbalizations. We are also going to look at engagement, which is the doll is within arm's reach, and then interaction would be holding, touching, or talking to the doll. So the independent variable is going to be the introduction of baby doll therapy. Pretty simple. The participants in this study. In general, they're going to be residents at a memory care facility. They need to have a diagnosis of Alzheimer's disease and signs of dementia. So some people with Alzheimer's do not have dementia. Some people with dementia are not diagnosed with Alzheimer's. So the participants would need to have both. I would like them to be in different units or different areas of living to ensure that the participants don't interact. So participant B shouldn't see participant A's doll or vice versa. And then some of the must-haves, sadly, participants should not be their own guardian. And this is for consent reasons. The ethics behind having someone consent who will forget or not know what they're signing would be wrong. So we would have to pick people who are not their own guardians. I would want to explain what we were doing and give as much information as I can, but at the end of the day, they wouldn't be signing their own consent. So they should all be within the 6th stage of dementia. So dementia has different stages, and the 6th one is when you would start to see a decline in language. And it's going to be important for them to be in the same stage, because comparing someone from stage 4 to stage 7 would be misleading, because someone in stage 4 has a lot more language and doesn't need help as much as someone who is close to death in stage 7. A doctor or a physician on site would need to diagnose that or label it because it is a subjective measure. It's not a clear test that you can get. So I want someone like that to define that. So ethically, in my opinion, it is a little undignified to give any adult a doll to carry around. But if the intervention is therapeutic, it may be worth doing it. There also may be modifications that we can make to make it more dignified. Some teenagers in classes in high school carry around fake dolls. It's not undignified for them, so maybe there's some way that we can make this more dignified if it's worth it. So that being said, I think that it is more unusual for an adult male to carry around a doll than an adult female. And it's not because females should only raise kids or that males don't know how to raise kids. I just think that in the grand scheme of things, it would be a little more undignified for a male to be carrying around a baby doll. So for my study, I would only pick females. The material's pretty simple. I would just want a way to collect data, so either a data sheet or an iPad, and then we would need the doll for doll therapy. The design of this study is going to be a multiple baseline design across participants. I would use 3 subjects, 3 participants, and I would use a 4th. The reason I would use a 4th, they will stay in baseline the whole time, is to account for any reactivity. So there's a scientist or a researcher at the clinic, let's all start interacting more. That could skew results. So I would want a 4th person there. If their interaction started to increase or their verbalization started to increase at the same time, we would know that there was some reactivity. Or if there were any center-wide changes. So if on one of the professional development days they had someone come in to talk about language, and then all of a sudden everyone started to have more language, this would be accounted for in that 4th person not receiving any treatment. So participants would randomly be assigned to A, B, C, or D. Ben talked about the importance of randomly assigning people to this so that the least affected person doesn't get A and the most affected gets C, something like that. Implement the intervention. So there's different ways that you can decide that. Sometimes in a multiple baseline, once the data is stable, the intervention is implemented. I'm assuming that data will be stable for most of the participants. This doesn't really give any time, so I wouldn't use this method. Another way is once participant A reaches some sort of mastery criteria, participant B then gets intervention. Once participant B gets a mastery criteria, participant C. I don't know if there will ever be a mastery because I'm going in kind of blind. I don't know what the effects of this treatment will be. So this one wouldn't work for me. I'm not aiming for an 80% of anything. On a skill acquisition or a gnome therapy, this may be a good option, but for me it's not. So the last one is to randomly decide. So I may randomly decide that participant A is going to start intervention after 5, participant B is going to start intervention after 9, participant C will start intervention after 11 sessions. I'm curious if anyone else has any other insight on this, because Ben and I were discussing how there really isn't a right or a wrong way to pick when to do intervention, which is a little odd in a design. So I'm curious if anyone had thoughts about that. So the procedure. So a consideration that I want to make is that memory care staff are not really required to do much intervention. That's not to say that they're not great people and they don't help very much. I was very appreciative of them for taking care of my grandma for many years. But at the end of the day, they don't have a lot of intervention time. So one study found that elderly patients did nothing for 65% of observations, which is kind of sad and depressing. So using that same data, I wouldn't assume that baby doll therapy should be a really intensive procedure. So the first step would be to train. So I would train participants, or I'm sorry, I would train. So the first step would be training. I'm going to train the data takers to detect examples and non-examples of vocalizations. Then I need to train them to use a 15-second partial interval recording. That can be confusing to some people, just marking occurrences, not tallying. I would use a 15-second partial interval, so I want to make sure that they know exactly how to use that. I'm also going to train other people, essentially the staff on the unit, to not evoke conversations during observation. But I also do want them to respond if asked questions, because I don't want to put anything on extinction. So a good answer would be, yes, I do have kids, if they were to be asked if they had kids. A bad example would be, yes, I do have kids, thanks for asking, I have 3 boys, what about you, do you have any children? That would evoke more conversation and give us more vocalizations than would be natural. So I would want to make sure people are responding with very short phrases so that I get accurate responding. So for baseline, we would observe people for 5 minutes a day, a 5-minute break or transition time. So that would be a total of 25 minutes per day. And we would randomly pick times between 12 and 3 o'clock. So it's important to randomly pick those times so that we're not always measuring 1 o'clock for participant A, 2 o'clock for participant B, and 3 o'clock at nap time for participant C. So we want to randomly pick those times. The third step would be to do doll therapy. So introduce that to participant A, and then B, and then C, according to that schedule that we're going to pick in the previous step. So additional data that I mentioned earlier would be, is the doll within arm's reach? So obviously we wouldn't take this in baseline, but we would want to take this during the intervention. And then, is the participant being interactive with that doll? And so engagement would look like touching, holding, or talking to. So then I also wanted to add in a booster session. So people with Alzheimer's or Alzheimer's disease is degenerative. So the idea is probably along the way or during intervention, participants will likely stop engaging with this doll because they simply forgot about it, right? That is what Alzheimer's is. So if engagement fell below a certain number, I'm guessing 50%. So if less than 50% of observations, the doll isn't even around, we should do a booster. I just kind of made up that number. If anyone has any other ideas, let me know. So if it falls below 50%, we would run a booster session, which would be reintroducing the doll. So there's videos if you want to look them up online, but you introduce the participant to the doll, ask what the name is, do all the bells and whistles. So that would need to be done again. I wrote this in here, I wasn't sure, but I would guess that if there was another drop, that we would probably just have to discontinue, because there's no sense in going around and around. We would probably need to think of a different intervention or just stop using this intervention. But that was my idea. So that was the end of the study. But during this time, I kept thinking about a study that we read in one of our classes. So Brensky, Red, Schultz, and Rapp, 2008. They worked with patients with dementia, and they implemented a procedure called descriptive prompts. So they mentioned the item. If the person with dementia doesn't engage with the item, the experimenter works with it or plays with it, models, quote unquote, how to engage with it. And then if the person with dementia starts to engage, they get praised. So using that, I couldn't get that out of my head while I was doing this. If successful, so if doll therapy ended up being something that produce results, I would want to do an alternating treatment design with doll therapy and a preferred item. So this study used preferred items and they saw an increased engagement. They didn't take data on verbalizations or social skills, which they should have. But if it increases them for them, I think it would increase here. So we would do an alternating treatment design with the fourth participant who hasn't received it. I would want to use that fourth person because the 1, 2, and 3, or A, B, and C, have had this doll for a long time, so I wouldn't want to use that same person. We would do a preference assessment to find some items that that person liked, and then treatment A would be doll therapy, so maybe Monday, Wednesday, Friday, and then treatment B would be descriptive prompts with preferred items. So descriptive prompts would be for both the doll and the preferred item. We would randomly alternate that, of course, so it wouldn't be Monday, Wednesday, Friday. We would want to make that as random as possible. And then we would do the same observations. So same as before. And we will want to do observations some number of minutes after, just to get that good effect to see if either of them were effective. So that's my presentation. Thanks for listening.